Good morning, everybody. I hope everybody will start a nice Toronto. And you are attending the first session of a week-long series of events, webinars, and discussions about living kidney donation and living organ donation. This is the Living Donation Week, organized by the Center for Living Organ Donation at the University Health Network in Toronto. Health equity, access and equity in living kidney donation and living kidney transplantation. We have a series of international speakers who are international leaders in both research and clinical change implementation in this area. And the events that we are living through, this is a very timely session, and it's important for us to reflect on these essential questions that we face in our everyday practice. The session, a perspective from the United Kingdom, then we'll jump over to the United States, and then review some of these questions that are the way they are seen from Canada, and we eventually practice from that perspective. At this point, we plan to have a question and answer session at the end. Please use slido.com with the code AM1. AM1A is the code actually for Slido to send in your questions. If there are pertinent questions at the end of that individual presentation, and have a brief question and answer there. But at this point, we plan that all the questions will be asked at the end of the 4 presentations. As a reminder, this session will be recorded. It will be available for subsequent views on the YouTube channel of the Center for Living Organ Donation, UHN. I guess the next step is that I will introduce our speakers. And again, just keep on reminding everybody that if you have questions, please send it in using the Slido platform, which is at slido.com. And the code for this presentation, this session is AM1A. So let me first introduce our speakers, and then I can pass on the microphone, and we can start this important session. The first speaker will be Professor Kurt Randhawa from the United Kingdom, who is a professor of diversity in public health, and he's the director of the Institute for Health Research at the University of Bedfordshire. He is also the director of the UK Organ Donation and Transplant Research Centre. His research is focused on the development of patient-centered care pathways in chronic conditions, including diabetes, chronic kidney disease, transplantations, and also end-of-life care. And he has been specifically focusing on these issues in diverse communities. He has been working with many colleagues internationally, including colleagues in the UK, European Union, Middle East, Qatar, Australia, Pakistan, and India. The UK Organ Donation and Transplant Research Centre has carried out extensive research examining variations in organ donation rates among different ethnic and faith communities. And currently it is carrying out a feasibility study to look at whether primary care physicians can play a role in organ donation, donor registration, and improving transplant rates and potential living donor transplant rates. Dr. Randhawa was recently commissioned by the National Health Service Blood and Transplant to develop the Faith Engagement and Organ Donation Action Plan, which was published in partnership with faith leaders. And he also importantly holds a number of policy and practice positions, such as he's the co-chair of the European Working Party on Public Issues in Organ Donation and Transplantation. He's the chairman of the Transplant 2020 stakeholder group, He's a national member of the National Black and Minority Ethnic Transplant Alliance. And finally, he's a national member, Organ Donation and Transplant Strategy Steering Group with the National Health Service Blood and Transplant in the UK. So obviously, he's very well positioned to share his perspectives and perspectives in general from the UK. The second speaker in the series will be Dr. Amit Garg from Canada, from London, Ontario. He is a professor of medicine, epidemiology, and biostatistics at the Western University in London, Ontario. He's also the site director of the Institute for Clinical Evaluative Sciences, the Western facility, and he's the provincial lead for the ICES dialysis, kidney, and transplantation program. He practices general nephrology, and he's also, importantly, the director of the Living Kidney Donation Program at the London Health Sciences Centre. Dr. Garg has been extremely active and successful in clinical health services and population health kidney research with probably close to 400 peer-reviewed publications. Very impactful ones, including research that included the introduction of new information for living kidney donor candidates as part of the informed consent process, and also other areas of chronic kidney disease, such as the impact of specific E. coli infections that made to the courts and had an important impact there. Also, he has been writing about drug prescribing, safe and unsafe prescribing practices, potentially causing acute kidney injury. And certainly, again, the impact of that research was indicated by label changes by the US Food and Drug Administration. He has also served on the board of the Canadian Society of Nephrology. He was the president of the society. He co-chaired the International Kidney Disease Improving Global Outcomes KDIGO clinical practice guideline process, and co-chaired the Living Kidney Donation Committee. And he is serving on the Living Kidney Donor Advisory Committee of the Canadian Blood Services, and also he's the medical lead for the Ontario Renal Network, that is the main funding and directing body for kidney care in Ontario, and he's the provincial lead for kidney transplant. And in that capacity, he's leading an important provincial quality improvement process, the ENACT project that is aiming to improve kidney transplant, access to kidney transplant, and specifically access to living donor kidney transplant in Ontario. He has received numerous grants and awards, and he's also sitting on numerous committees. He's on the editorial boards of American Journal of Kidney Diseases and JASN. He received the National Kidney Foundation International Distinguished Medal for his research contribution, and multiple other awards. So he will be talking about overall systemic approaches to equity in living kidney donor transplant. And I just realized that he will be actually speaking third, because the second speaker in the series will be Dr. Taniela Purnell, who is an epidemiologist and health services researcher with more than a decade experience related to identifying and addressing patient, family, healthcare system, and community factors influencing health and healthcare disparities for adults with cardiovascular disease, risk factors including hypertension, chronic kidney disease, and diabetes. She's an assistant professor at the Cardiovascular Disease and Clinical Epidemiology at Johns Hopkins Bloomberg School of Public Health. She holds joint faculty appointments at the Johns Hopkins Departments of Surgery, Health Policy and Management, and Health Behavior and Society. She has multiple other roles, including an associate director position at the Johns Hopkins Urban Health Institute, where she co-leads the Institute's efforts to facilitate and recognize collaborations between communities, universities, healthcare delivery systems, government, and the private sector to build a collective capacity for achieving health equity in Baltimore, but also in a broader society in the United States. She's also the Associate Director for Education and Training at the Johns Hopkins Center for Health Equity, where she leads the center's award-winning educational training programs for public health, nursing, and medical scholars working to advance health equity. In addition, she is the Director of Community and Stakeholder Engagement for the Hopkins Epidemiology Research Group in organ transplantation, core faculty at the Raj Center for Prevention, Epidemiology, and Clinical Research, and an affiliated faculty with the Bloomberg American Health Initiative at the Center for Health Services and Outcomes Research. She is one of the lead researchers working on health equity in transplantation and other chronic conditions. She is a native of the Mississippi Delta and a proud alumna of the Tugaloo College, where she obtained her bachelor's degree in computer science. She has received several national and international research honors and has published findings from her work in leading medical and public health journals, including the JAMA, Health Affairs Journal of the American Society of Nephrology, American Journal of Hypertension, and so on. She has certainly published many of the key pieces that inform us about health equity and equitable access or inequitable access to transplantation and living donation. She is deeply committed to community service, teaching, and mentoring, and she is a recipient of multiple teaching excellence awards from Johns Hopkins. Again, I think she's in an excellent position to share her research and also her perspective on the issues that we try to have a better understanding on. And the series of talks will be concluded by a talk by Dr. Amy Waterman, who is a transplant innovator and a professor in residence at the University of California, Los Angeles, within the Division of Nephrology. She is the Director of Transplant Research and Educational Center and the Deputy Director of the Parasaki Research Institute. In addition to many national transplant leadership positions, Dr. Waterman is a Fellow of the American Society of Transplantation and serves as a Research Committee Chair for the National Kidney Registry, a exchange program. In 2019, she received the American Society of Transplantation Clinician of Distinction Award. In 2018, she received the Claremark Award for Distinction from the Center for Plain Language for Interactive Digital Applications. That is called My Transplant Coach, as well as the National Health Information Merit Award for 2 educational initiatives developed by Explore Transplant, a nonprofit consortium that Dr. Waterman had founded. Through her research and educational initiatives, Dr. Waterman seeks to understand the critical modifiable patient, provider, and systems barrier to kidney donation and living donor transplant. She also designs interventions to overcome these barriers. The mission of her laboratory, the Transplant Research Education Center, is to inspire and educate people about kidney transplantation and living donation and reduce racial, socioeconomic disparities in transplant. Its vision is to increase transplant and living donation rates and solve the kidney donor shortage. The center focuses on translating the findings from effective clinical trials into everyday practice through collaboration with healthcare providers, transplant leaders, and policymakers. Dr. Waterman is driven by 3 core beliefs. One is that transplant-eligible kidney patients deserve to make informed choices about their treatment options, especially disease or living donor kidney transplant. Second, there are many generous people who may become deceased and living kidney donors, but they need to learn what donation involves. And finally, if we all work together, kidney patients, their families and communities, and kidney healthcare professionals, our collaborative efforts can reduce the national kidney donor shortage and increase the number of people living longer with the benefit of kidney transplant. Similar to the other speakers, she received a PhD during her studies. Her degree is in social psychology with an emphasis on patient education and behavior change from Washington University, St. Louis. where she was a faculty member until she moved to Los Angeles. So before moving in, I think just to summarize what we heard from the bios of the speakers, we will be talking about broad systemic issues that are very relevant and sometimes painful in the current times. But the systemic approach and the deep understanding will need to be intertwined, and it is intertwined in the work of the presenters with personal beliefs and personal action, so that some of the inequities and injustices that we will be discussing will be overcome, hopefully in the not too distant future. So at this point, without further ado, I will hand over the microphone to Dr. Gert Randava to start his talk. And again, to remind everybody, if you have questions, please submit it through Slido. The code is AM18.
Thank you very much, and good morning to those of you in Canada. It's a lovely and unusual sunny afternoon in England at the moment, and it's an absolute pleasure to join you at the beginning of your donation week in Canada. We've just had our donation week in the UK, ended yesterday. So I'm going to spend the next 15 to 20 minutes discussing some of the progress we've made in the UK, but also some of our candid lessons in the spirit of sharing and openness and transparency. So just sort of thinking this through, the journey to access and equity is really a story that's ongoing. It's not a static process. It's actually a very dynamic process. So this is just an image of Europe, and it just shows, here's the UK, it just shows the percentage of foreign-born people in the UK, but also here's France, Spain, Germany, etc. Here's Italy. And I've just put this up here just to show you that sort of immigration is a global phenomenon. And what's improved is because our ability to collect data is improving, the debates we're having now around access and equity, they're able to take place in a more nuanced and evidence-based and sophisticated way. But the point is, access and equity needs to be an ongoing challenge. It's not something that's ever going to be solved overnight. And we all need to work together, which is why I'm so pleased that we've got this webinar today. And this, just to give you a bit more granularity, shows you across Europe the countries from which the main immigrant communities reside. So again, in England, the majority of the foreign-born immigrants are like my parents, who came to England in the 1960s from India. In Ireland, they're from the UK. In France, they're from Algeria. In Spain, they're mainly from Morocco. In Italy, it's mainly from Romania. In Germany, it's Poland. And I just show this because it gives you a bit more texture about the kind of globalization we're seeing. And it's important to think about this as we develop health and social care and start to think about the challenges around kidney donation and kidney health more generally. So here, when you look at population projections, I'm sure you've all seen very different versions of this. The blue line is the UK. It's predicted that by 2050, if you compare the UK, the Netherlands, the US, Germany, and Denmark, the UK has a trajectory of being one of the most, if not the most, diverse populations in the world. And as I said, in parallel with that, it therefore impacts upon the planning and commissioning of our healthcare, and really makes it really important for us to start thinking about culturally competent care and planning for issues like access and equity. So in terms of my research, what I've been looking at is, as a public health professor, I'm quite interested in the whole pathway. So in an ideal world, I'm quite interested in people not becoming ill in the first place. You know, that would be utopia. But we know that our rates of diabetes, high blood pressure, kidney disease are much higher in our South Asian communities, those from in the Indian subcontinent, much higher in our African Caribbean communities, and also now growing in our next biggest growing community now in the UK is actually from Poland. And they're also beginning to see high rates of diabetes and blood pressure. What's happening now is we're beginning to see a higher proportion of dialysis patients from those communities. And then on a human level, what do those people do? So if they don't get a transplant in the UK, and I'll explain why they may not in a bit, some of them understandably look for alternative options. So some of them go overseas for a transplant, many of whom, for example, go to their countries that they originally arrived from. Others, quite sadly, engage in transplant tourism. And although we know it's illegal, the harsh fact is some people feel they have no alternative. And we need to obviously support them to make a different choice if we can. But also in the UK, there is this issue that there are reduced opportunities for transplantation, especially amongst our minority communities. And overlaid on that is the fact that there's much worse end-of-life care, if any end-of-life care, for those people who are now too ill to receive a transplant. So a whole host of issues, all the way from prevention to management and treatment of kidney health. So if we look at living donation in the UK, we can see that they make up about 40% of our total donor pool. And in the last financial year, 14% of all living donors were from our non-white communities, which is not bad. And 18% of our living donor transplants were with BAME patients, which is pretty good. And as you'd expect, most of our living donation is mainly of the kidney, so 98%. And in the UK, 80% of those waiting for a transplant are actually waiting for a kidney. And living donors make up 40% of all kidney donors and 28% of our transplant program. So it's quite a sizable program. But as I suspect we'd say in all countries, if we could really bolster our living kidney donors, we could have a huge impact on reducing the transplant waiting list. And these are just figures for the last 5 years. And essentially what these show are that there's a 4% fall in our waiting list, which is good news. There's nearly a 30% increase in our transplants, which is also pretty good news. But there has been a decline in our living donors, but there has been a massive increase in our deceased organ donors. So like all countries, we're making some progress in some areas, but less so in others. And clearly living donation is something we want to improve. Now, thinking specifically about our Black and minority ethnic communities, I think this for me is my most interesting slide, which is available from the NHS Blood and Transplant website if you want to get more details. So roughly speaking, in the UK, 11% of our population is non-white, i.e. Black and minority ethnic communities. And this slide eloquently paints the conundrum of the UK donation and transplant issue. However, although we make up 11% of the population, we only make up 7% of the people registered on the organ donor register. Now, there are caveats to this data because this is only 7% of the people who've declared their ethnicity. So it could be higher than this. However, when you look at the opt-outs, nearly 80% of opt-outs on the UK. In the UK, we are in an unusual position. We have an opt-in register and an opt-out register. There's a much higher proportion of Black and minority ethnic communities on the opt-out register. And disproportionately, you can see that although we only make up 11% of the population, we make up nearly a third of the transplant waiting list. And that's all to do with higher rates of diabetes and kidney disease. and high blood pressure, hence the need for a pathway approach to kidney health. We make up just under 10% of eligible deceased donors and just over 7% of actual deceased donors. And as I said, we're doing quite well in terms of living donation, doing quite well in terms of transplants, both deceased and living. But in a sense, here's our conundrum. We're doing well on living donors, well on deceased donor transplants and living donor transplants, but not so well on deceased donors, eligible deceased donors, not so well on waiting lists, not so well on opt-out, and not so well on opt-in. Hence, I think our challenge is, how do we take a systems approach to solving these issues rather than only focusing on either transplantation or donation or on prevention and management? It really needs to be the whole pathway, which is what I'll describe about some of our work now on community engagement. So this is essentially my work. So I've been working for the last 20 years with communities of different ethnic groups. And essentially, although, and I mean this in the politest way, most governments and healthcare services are very focused on organ donation, when you actually speak to public and communities, and I guess, September 2020 is a good time to have this conversation, countries are actually, communities are really interested in the issue of trust, because unless they trust the government and they trust the service providers, they're never ever going to entertain the idea of donating organs, donating blood, donating stem cell, etc. And the only way they're going to build trust is if you start to tell the story about how organs are retrieved. So what's the process and where do these organs go? And this is all part and parcel of building trust. And most importantly, it's about who is conveying these stories. Because with all due respect, not just to myself, but many of the people who run these campaigns, they tend to be either clinicians or academics. And although we are fairly well trusted amongst the community, the people who are most authentic are the people from that community who've actually gone through the lived experience of either being a living kidney donor or being a donor family member of a deceased donor, who can only openly and honestly talk about their experiences of how those organs were retrieved, how their life was impacted. So essentially that model I've loosely translated into something what I now call messages and messengers. And I'm just going to very quickly run through this. So essentially this gentleman here, he's a gentleman who's actually donated one of his kidneys. So when we run community events, he's able to talk vividly, honestly, about the highs and lows of being a living kidney donor, and about his honest experience about how he's struggled with his diet and lifestyle since being a donor, but he's so pleased he's done it. And I think that really does build trust and engages communities. Here's a recipient. Here is another donor. This gentleman is the brother of a deceased donor. This lady is a recipient of a kidney. And other people on these slides are either clinicians or even community leaders. But essentially what I'm trying to convey here is that we've got to really take a multifaceted approach to building a dialogue with our communities. And only if we do so, and not just talk about donation, but also talk about improving kidney health, preventing kidney disease, are we really going to develop long-term sustainable systems-wide solutions to these issues. So just an example I want to share with you, and this has been led by NHS Blood and Transplant and the National BME Transplant Alliance. They, in the last 4 years, have been running something called the Living Transplant Initiative. And it's been a wonderful pilot scheme where they've been trying to now increase living donation amongst our Black and minority ethnic communities. And it's all community-led. So these are projects led by community groups here listed on the left, 4 different demographics, So it recognizes the heterogeneity amongst our different minority communities. It also recognizes the different locations in the UK, but most importantly, it recognizes the community-based assets that we have, and we should never within these communities. And there's been some more recent projects. Again, this one's in London, another one in Leeds, another one in Birmingham, all to do with different communities within our Black and minority ethnic communities. And as I said, all mainly to do with building community awareness. And also we've been piloting a peer volunteer home education program. But essentially, it's all focused on this whole idea of having different messages and different messengers suited to the communities. And how these projects are being measured. So we're looking at the number of people who've now expressed an interest in being a living donor, number of people who started the donor assessment process, and ultimately the number of people who donate a kidney. So what's been learned? There's again a report that you can access from this website at the bottom. What we know is, which has been a fantastic outcome of these projects, is that if you have tailored faith-based educational materials, then people are far more likely to engage. And as I said, this is all going back to building trust in the communities. Community events are really good in terms of raising awareness. However, as I said, in the spirit of sharing, of those who expressed an interest in donating a kidney, very few have proceeded to assessment or donation within the lifetime of these projects. Now, that's not to say it won't happen. It's just in this time frame that hasn't happened so far. But it has fostered very positive collaborations between the community leaders and transplant professionals. And ultimately, the key learning has been that if you have targeted community-tailored education led by the community themselves, it's going to be far more likely in increasing living donation amongst these communities. So the current plans now are to really focus on increasing living donation amongst the Black and minority communities, especially in the lower socioeconomic groups. So the plan is to run a few more projects and then report back next year. But as I said, this is all about building trust and about focusing on different communities. And here are a summary of those projects. So this one's in Scotland, here's one in the south of England, this is in London. Unfortunately, and I suspect this is true globally, a lot of these community projects are being affected by COVID-19. But the key point is the learning will be very important as we start to plan, hopefully, once we come out of the COVID pandemic. So the next steps are to obviously produce a report to share with people, and then think about longer term investment, targeting particular communities, so we really do get living donation embedded into our society and really focus on reducing health inequalities in our different programs. Just some reflections from me, which I think is important to share really, is, and this goes back to where I started off from, if we're going to think about equity and access, we really do need to think about collating and using data. And although in the UK we're doing our best to collect data on ethnicity and issues like religion, we're not really good at it. We're not brilliant at it. We need to be better. And the only way we're going to get better is if we do genuinely start to build trust within these communities. And I'm sure you've probably seen on the news, and I'm sure it's been an issue in many other countries, we haven't really covered ourselves with glory in the way we've handled COVID-19 with our different ethnic communities. And all of these issues impact upon each other. So you can't think about kidney donation in isolation to other issues. So we've really got to think about how we collate data. And therefore, there is this debate, which I'm sure many countries are having, about how immigration is described and talked about. And in the UK, as you'll probably know, we're going through something called Brexit, which again doesn't really portray immigration in a positive way and doesn't really make people feel valued. And therefore, we need to consider how these politics impact upon issues like donation and transplantation. It would be really naive to think they don't impact upon donation and transplantation. So we have to be mindful of this political debate. And some of the standard solutions I would argue for is we need to have cultural competency embedded in national policy making. It needs to be embedded in organ donation campaigns. And ultimately, we need to be able to measure it. We need equality impact assessments of all transplant waiting lists and organ allocation programs. And we need to ensure that the debate and dialogue of organ donation is ongoing with all communities if we want transplantation to be sustainable. So that's been a really quick canter through. The person I'd like to thank the most, and I think every person in the country needs someone like this. So we have a wonderful person called Lisa Burnap, who works at NHS Blood and Transplant, who leads our living donation work. And she's got one of those unique talents that she's able to straddle both the policy making, but also the community engagement work. So if you're able to, contact Lisa. And, if we could, I would advocate cloning her, but I'm sure we can't. But thank you so much for giving me this wonderful opportunity, and look forward to the questions.
Thank you very much for this presentation and providing important material for thought and for discussion at the end. At this point, I don't see any specific questions that would require immediate attention. So we'll save the questions to the end of the 4 presentations. So the next talk will be presented by Dr. Tanyala Purnell from Johns Hopkins University from Baltimore. And I just passed the microphone on to Tanyala, who will talk about living donor kidney transplantation and the African American communities in the US. And thank you very much, Tanyala, for saving the time for us, and looking forward to your talk.
So thank you so much for the warm introduction and for the invitation to talk to you today. This is a very important event, and I will say hello to everyone. It is also morning here in Baltimore, and it is a beautiful morning. So I'm thankful for that. And so we will get started. So I like to just jump right into it. So what is the problem? We know that we're talking about perspectives from different countries. And we know that, in terms of kidney failure and the national burden, this is also a major issue here in the United States. In particular, as with many chronic conditions, we see a disproportionate burden in the southeastern United States, but also in other parts of the country, including California, and in particular, the lower part of California. And so when I show this slide, I often ask people to weigh in on, what could be going on. And, people talk about the different policies at the state level, thinking about things like expansions of Medicaid, but in particular, just thinking about the burden of the major risk factors for kidney disease, which, as you know, are diabetes and hypertension. And so unfortunately, many of the same areas where we see a large burden of kidney failure are those same areas where we see major risk factors for kidney disease, and for which we know that it is harder to find living donors because, of course, we want people to be healthy. So these are, just some of the trends coming from our USRDS, so United States Renal Data System, annual registry analyses. And so in terms of looking by race within the US population, we see, in terms of the prevalence of ESRD, we see a disproportionate burden among Native Hawaiian Pacific Islanders, Black African Americans, then followed by American Indian, Alaska Native, Asian, and then white, non-Hispanic white Americans at the very bottom. Also, when we look by ethnicity, which is defined in this country essentially as Hispanic or not Hispanic, we see that there is a larger burden among the Hispanic as compared to the non-Hispanic ethnicity. However, when we look at our rates of living donor kidney transplants, we see almost the exact opposite of what we just saw in the previous slides in terms of who is most likely to experience end-stage kidney disease. And so, as you can see here, non-Hispanic white Americans have the highest rates of living donor kidney transplants, followed by Asian Americans, and then sort of mixed in between, we have Native Hawaiian, Pacific Islander, American Indian, Alaska Native, and at the very bottom, we see Black African Americans. And so we know that this that something doesn't quite seem right with this, and we've known this for a while. We've seen this in many other conditions, and what we are generally describing, is really something that falls under this broader umbrella called health disparities. And so, one definition of health disparities, according to the WHO, is that we can really define these as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And where we truly want to go is a state of health equity, where every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this because of social position or other socially determined circumstances. And so that is also something that is very relevant for this issue of living donor kidney transplants or just living donor transplants in general. And so again, when we don't have a healthy population and when the burden of chronic illnesses repeatedly fall upon certain groups, then this again impacts our pool of potential donors. And it reflects what happens in terms of disparities in actual rates of living donor transplants. So one thing that I found recently that is important to talk about is what is the definition of race as it relates to how we measure race and how we interpret and how we should interpret the findings here in the United States. And so what we do know is here in the US, most of what we generate regarding differences by race is essentially an attempt to collect data that's usually self-reported or provider-reported within either surveys, within national registries, or within some other large data set. And again, this is self-identified. So this is not to be confused with true basic science studies that do genetic ancestry analyses, which, as we know, based upon the results of the human genome, is that there's lots of variations across these so-called racial and ethnic categories, and there's no clear distinction among a particular group of people under a particular label. And so I went to the US Census website because many of the categories we use really adhere to these same 1997 US Office of Management and Budget standards on race and ethnicity. And what they say is that the racial categories included in the census questionnaire, which is what we typically use as the basis for our categories, generally reflect a social definition of race recognized in this country and not an attempt to define race biologically, anthropologically, or genetically. And so I think that that's important to really think about when we are interpreting the findings and thinking about the why, how do we get here? And in particular, again, when we're using these self-identified or provider-reported categories, what is truly going on? We also have a consensus report that came out about 2 years ago in JAMA from several leaders of NIH institutes, really where they brought together lots of experts who basically said that there's a lot of confusion about how findings are interpreted within biomedical research. But one of the things, which as you'll see is highlighted in red here on the slide, is that they really warned investigators against reporting information that could perpetuate the myth that race, as we typically use it here, is a biological fact. So again, just being mindful of how we interpret these findings and what could truly be going on. So in light of this, we then think about, well, what could be driving these factors, right? So this is not new information. We've known that there are disparities in living donor kidney transplant for as long as we've been collecting data about it. So what, could be happening here? A few years ago in 2012, we published a paper where we essentially wanted to document what all of the reported barriers were to living kidney donation within the published literature. We used as a basis for this the social ecological model, which is a major model that we use in public health. And essentially, what we know is that many of the same barriers that potential living kidney donors who are African American or Black, Hispanic, and other groups typically report experiencing are many of the exact same factors that are driving disparities in other chronic illnesses, to be frank. Also, we know that these factors are not functioning within a bubble. We cannot say that if we develop interventions that solely target individual patient factors or individual family factors, that we should then automatically see changes. Because as you can see reflected on the slide, there are multiple factors that are all happening at the same time at multiple levels of influence, and they interact with each other. So for example, yes, if we focus on the potential recipient or potential donor level, we know there are differences in clinical suitability because there are differences in chronic disease burden, which means that for some groups, including Black and African Americans, it's harder to find living donors who are clinically suitable within families and close social networks if we have many of the same shared risk factors and many of the same experiences of disease. We also know that there are concerns. People want to know what happens to living donors long term after this surgery. So, for example, we've experienced people who are considering whether or not to pursue a living donor kidney transplant or whether or not to even talk about it with their family members. And one of the first things that they say, in particular among the Black and African American community, is, if I ask my son to donate to me, even if we are able to convince them that transplant is the best option for them, the first question they say will be, will this make my son end up on dialysis just like me? Will this make my brother on dialysis just like me? And if it will, then many times people are not willing to move forward with that conversation. Or if we are not able to convince them that the best available evidence really applies to that particular group, then they're also concerned. So thinking about informed consent, thinking about things like, some of the recent projections about who is most at risk for graft failure or rejection, or even thinking about, the things like long-term expenses related to the immunosuppressant drugs for transplant recipients. So here in the US, Medicare is a primary payer for end-stage kidney disease. However, if you receive a transplant, and if you do not otherwise qualify for Medicare, typically being age 65 or older, your eligibility for Medicare ends 3 years after the transplant, which makes absolutely no sense. Because as we know, we often see around that 5-year mark, 10-year mark, we often start to see graft failure rates. So it doesn't make sense to then end coverage for this life-saving treatment. But we also know that things happen in terms of the individual encounters that people have with their providers in the healthcare system. I know Dr. Waterman is coming later today, but we think about things like a communication and education about transplant, the timing of it, the quality of it. How are those conversations influencing what happens in terms of moving forward? And even when people present, including both potential donors and potential recipients, there are many barriers that people often face while trying to get through the evaluation process. And so here in the US, the experience, even for people who make it to the door of a transplant center and attempt to start the evaluation process, often there are very low rates in terms of who completes that evaluation process. And over the last few years, I've been investigating some of the reasons why. And part of the reason is because it is a very convoluted process. Many times, both the transplant coordinators and also the potential donors or recipients themselves have no idea where people are in the process. There are lots of lapses in communication. There are lots of things that can cause confusion. And to be frank, many times this process can be dragged out much longer than it has to be. For some people, this process could last for a month. For others, it may take up to 1 year to get through this process. So how does that influence what eventually happens as well? And so thinking about, again, all of these factors and how they play a role. Also, as I mentioned earlier, this is not new information, which means that there have been very smart people who've also been working on this topic for a very long time. And we have seen, some promising evidence, even if it's just at the center level or local level, for some of the different trials and programs that have been tried. In particular, we know that there has been a very heavy emphasis on education targeting donors and potential donors and patients. So this includes home, community, and clinic-based programs. But we now also see an increased initiatives to extend this to social networks using social media, for example, to identify living donors. What we don't often talk about is the fact that we know that there are major cultural differences in terms of who is willing to share their medical information with the broader public. Typically, that is not something that is as widely acceptable within the Black African American community and Hispanic community as it is among the non-Hispanic white community. And that also has implications. So if our focus is on trying to convince patients to then share their experiences with strangers in hopes that people will show up, and if patients have reservations about using that, then there's also, a potential to help widen the disparities if that's something that is truly helpful for only a few groups. But then again, as our prior speaker said, we know we need to have culturally appropriate and culturally sensitive education and behavioral programs. Communication matters. Trustworthiness matters. So relationship building between providers and others with potential families, with potential donors, with potential patients, with actual patients matter in terms of whether or not people are willing to listen, to trust the information that's being provided to them, and to move forward with what is a very complex process, to be quite frank, especially for patients who are already trying to stay alive. Trying to stay alive on dialysis while also trying to maintain your life as a human being is complex within itself. And now the added burden of trying to identify a donor and trying to get through this evaluation process, that's a lot. And we need to be mindful of that. And we need to be able to provide more support for our patients, for our potential donors, outside of just what they encounter within transplant centers. We also need to help galvanize communities. We need to help galvanize the people who they interact with on a day-to-day basis to make this something that the general public knows about, is aware about, and is ready and activated to help our patients and help our potential donors. And so, this slide just talks about also other initiatives we know targeting the healthcare system, and then also the general population and trying to alleviate the chronic disease burden. We also know here in the US, there's been multiple federal and state pieces of legislation to support living donation in general. We know that most of this is focused on protected time away from work, or, for example, tax benefits. We now have a national program to provide some reimbursement for potential donors, for example, costs that they would not otherwise incur and that are not being covered by insurance. And so we know that this has happened. And I believe at last count, every single state has at least one piece of legislation that has been designed to support living donation. And so one of the things that we did a couple of years ago is really try to investigate, well, collectively, have we made any difference in these existing disparities in living donor kidney transplantation in the US? And so, we published our findings in 2018 in JAMA. And what we essentially found was that not only have we not made improvements in the disparity, we were, initially hypothesizing that worst case, they would remain the same. And I know that this is a busy slide, but I encourage you to read the broader paper. But I use this version of the slide so that you can see that we adjusted for several factors, including several confounders or healthcare system factors or SES data that was available at the neighborhood level and other factors. And here in panel D is the fully adjusted model. And so, the 1.0, the line is our reference group, non-Hispanic whites. And if a group or in particular, a point estimate is above this line, we know that that particular group at that particular time period experienced essentially better access to a transplant. And we also accounted for competing risks, which is what we call them in epidemiology. So we accounted for the fact that we know that there are also differences by race and ethnicity in terms of who receives a deceased donor kidney transplant and who dies while on the waiting list. And even after accounting for all of these things, we essentially saw that for Black, African American, and Hispanic patients, the disparities actually got worse over time, unfortunately. So as you can see, these point estimates are moving further away from the reference line, closer to zero. And what we found is that essentially for the Asian American population, it got, essentially a little worse, but also sort of remained the same. And so what it says to us is that we need to think about ways to scale up the programs that we see at the center level that are potentially effective, that could be programs that could be beneficial in other centers. We need to think about ways that we can get sustained funding at the national level to roll up these factors, to tailor them at the community level. We know that not every single program will work as is in every single population or every single clinic in actual clinical practice. And so that requires resources. That requires relationship building. That requires a long-term commitment to sustain changes. And that needs to happen at the national level. And so, as you know, we're also in the middle of a pandemic, right? So we already had these existing issues and then COVID hit, right? And so now, not only are our patients dealing with the fact that they're trying to stay alive, trying to identify a potential donor, trying to get through the evaluation process, but now COVID hits. And now staying alive has absolutely become the priority for all of us, right? But in particular for patients who are already very sick. We also know at the very beginning of this pandemic, many of the transplant centers here shut down their transplant programs and other, non-urgent, non-critical surgeries because everyone was trying to figure out how to best deal with this COVID-19 pandemic while staying alive, while not causing further harm to patients. And that's sort of where we still are now. So one of my nephrology colleagues and I, Dr. Deidre Cruz, published a perspective recently in JASN, where we talked about this idea of the nexus of dealing with COVID-19, dealing with overt acts of racism that are also very pervasive here in the United States, and people are aware of it worldwide, and also these existing racial disparities in kidney disease. And this is really trying to galvanize the kidney community and professionals to help to come together and really provide the types of support that our patients really need in this time, and at all times, to be quite frank, but in particular now. And so as you can see here in the box highlighted in red, there are many multiple consequences going on. For example, we know that the Black and African American community here has been one of the hardest hit in terms of the number of deaths, in terms of the number of severe hospitalizations, in terms of risk of transmission. People are dealing with that. People are dealing with grief. People are dealing with being socially isolated. So we think about older adults and others who are essentially just staying at home now. People are not seeing their family members in person. People are worried. I am worried. I have had multiple family members who have been impacted by COVID-19. I have had multiple family members who have died due to COVID-19. We are all dealing with this, and we're not all dealing with this across the board in the same manner. And we have to think about what that means. We also have to think about the fact that many communities were already food insecure before this pandemic. And now many families are devastated by this. If people are being laid off from work or are not consistently working, they then don't have access to food. We have not received appropriate benefits here in terms of making sure that people are able to meet their day-to-day needs. So thinking about food scarcity, thinking about worries about loss of employment, or thinking about the fact that many of the so-called essential workers, even outside of the healthcare encounter, including people who work at our grocery stores, including people who drive our buses and taxi systems, are disproportionately Black, African American, and Hispanic. So what does that mean if we're not providing appropriate protection for people? It means that they are at higher risk of transmitting these illnesses and also giving it to their families. So if we have patients who are living in multi-generational homes, and even if they aren't leaving the house, but if they have relatives who have to go out and work to stay alive and are coming back into the homes, what does that mean? And then thinking about the fact that we've really translated our care to healthcare, telecare, really across the board when appropriate here. So think about things like people who don't have a steady access to the internet. Thinking about things like people who are so afraid of leaving their homes or so afraid of coming to the hospitals that then they now are essentially allowing their existing chronic illnesses to get worse because they aren't receiving appropriate care. So we have to think about, really what all of this means in terms of now still being able to identify living donors and still be able to get through the evaluation process. We also have to think about structural racism and what that means in all of our countries. We have to think about how these systems of how neighborhoods were formed, how educational, in particular, public education systems are funded, how, these policy decisions, thinking about employment and who makes a livable wage, who doesn't. We have to think about things like the media and how certain groups are portrayed. And we have to think about criminal justice, essentially, and how these reinforce discriminatory beliefs. As our prior speaker said, trust is very important. If people feel discriminated against, or as many people often tell us, I'm afraid to sign up to be a donor because I'm afraid that if something happens to me, the hospital and the doctors won't do all they can to save me. And so if that's what is in the forefront of people's minds, then we know trust is an important thing that we have to build. And so, let's think about potential solutions just in the last couple of minutes. And so here at the Center for Health Equity, we try to think holistically about what it takes to really promote equity in health for socially at-risk populations across the board. We do this by conducting research studies to help advance scientific knowledge. But as the initiatives that I lead are sort of focused on, we help to train the next generation of scholars. We know that many of these problems did not develop in a single generation, and it will take multiple generations to address them. We partner with patients. We partner with community leaders and community organizations and faith leaders to try and tackle these issues. And then we also actively try to promote changes in clinical practice and policy. And we think that this is needed across the board, in particular for this topic. Some of the specific projects that I focus on are really engaging actual patients, their family members, faith leaders, community members, and trying to think about what are the barriers that people are encountering as they try to get through the evaluation process, or what are the barriers at the community level, and trying to bridge the gap. There are many community members and faith leaders who, once they figure out that there's a problem, they want to help. So it's our job to help them figure out how to help. I'm also partnering with faith leaders here, in particular among African American churches in Baltimore, to help address their stated COVID-19 and racism concerns. It's important for us to also ask community members what's important to them. And so we're developing a health equity educational curriculum about lowering our risk of COVID-19 transmission We're also working, again, holistically on trying to educate the population and trying to educate trainees. And so if you're interested, this is our email address, healthequitytraining@jhmi.edu, and our website, healthequityhub.com. And you can read more about some of our existing initiatives. But I would like to point out to you just two things. One, we have monthly research seminars, all focused on health equity, timely topics in health equity research. These are open to the public. Currently, we are doing them by Zoom. We normally do them in person, but the university is closed for in-person learning. And so we're doing it by Zoom. And so if you're interested, we're happy to add you to our email list. We also have 2 courses that are freely available on Coursera. They are MOOCs. One is called Foundations for Health Equity Research. The other is called Applications of Health Equity Research Methods for Practice and Policy. We currently have over 1,200 learners, and we believe that this will also just help to talk about and share what are some of the methods that we've learned in other topics, for example, diabetes, cardiovascular disease, cancer, and other areas, and how do we learn from each other to really tackle these issues more holistically. And so that's all that I have. But because, right now we're talking about such heavy topics, especially here in the US, I am often being asked, how do you even remain optimistic at all? How do you keep going when things seem to be getting worse, when things are, just so dire? And so I look to our civil rights leaders, including Dr. King, and this was one quote that I will leave you with. Dr. King said when he was asked, how do you keep going? How do you stay optimistic? How do you push forward? And he essentially said, while fighting for civil rights here in the US, I refuse to give up. I refuse to despair in this moment. I refuse to allow myself to fall into the dark chambers of pessimism, because I think that in any social revolution, the one thing that keeps it going is hope. And that's what, I hope to leave you with here today. The hope and the desire and the reminder that this is something we all have to commit to doing long term. We have to commit to making sure there are others coming behind us, and that we leave a blueprint for them to keep fighting for our patients, for our communities, for each other. We have an obligation as human beings, and we all have an important voice, an important thing that we can do. So thank you for listening, and I think that's it.
Thank you very much, Tanyala, for this presentation, and I think these are Gorch's and your presentation have already brought up a number of issues that hopefully we will have time at the end to discuss. These are very timely, very important presentations and thoughts. And just to mention and provide a plug-in for our next session, which starts at 11:10. Just wanted to kind of give a quick advertising here about the next session of this Living Donation Week, which will be about our national action project that looks at equitable access to living donor kidney transplant for South Asian and African, Caribbean, and Black communities in Canada. And we struggle with many of the same issues that both Gorch and yourself, Tanyala, brought up. And I think it will be quite interesting to discuss some of these topics that are essential, very heavy, very difficult, and we need to figure out some of the answers as we go, and it's very difficult conditions overall. So I just ask the team if there's any urgent question. I don't see any message, but Courtney or Matt, if there's anything from the Slido coming in.
There is one question that came in during Chanjala's presentation. I can read it out now.
Yes, okay.
How can transplant centers support patients whose cultural norms are against sharing their need for a living donor with family/friends/community in a culturally appropriate manner to enable them to access to LDKT?
Okay, so I think that you were asking, how can transplant centers work with patients who are culturally concerned about this? Was that the question? I think that something happened with my question.
Yes, sorry. So patients whose cultural norms are against sharing their need for living donation with,
Gotcha.
outside their circles. Yeah.
Oh, awesome. So that is a wonderful question. So first of all, I think that, one, that's an excellent question, but that also is something that I've had to deal with in terms of thinking about patients who are absolutely terrified to sign up to be donors because they truly are concerned. And so one of the things that I've tried to sort of do is really just kind of work to build a trusting relationship in general. And that takes time, right? So one of the things I've done is I go out to communities, I go out to churches, sometimes at night, sometimes on weekends. Over time have helped people to sort of address topics of interest to them, even if it's not this exact topic. And I've also worked very closely with other trusted agents in those communities so that when we have difficult conversations like this, then it helps to really start the conversation. One of the things that I've learned that many patients and many family members don't quite understand is that even if they hear language like, oh, well, in general, African Americans do well on dialysis, or in general, whatever, what does that mean? And if you look at our national reports, that still means an average life expectancy of 9.5 to 10 years. It still means a reduced quality of life. And so sometimes when I reframe it in a way to remind people that doing well on one option, it's great. We're glad you're still alive, but there are real consequences to not having timely conversations about the need. The other thing is sort of so that we don't put the full burden on the patient. We've been sort of focusing on helping to activate what we call champions. So other people who are willing to learn about these topics and help to speak on behalf of patients about the broader needs for more donors and, who may be willing to help share stories, even if it's not that patient's direct medical experience, while we're sort of working with them to feel more comfortable. And then finally, I've learned it's important to really activate the broader community itself. People know when we say cancer, people go, oh my God, that's a very serious topic, because they've done an amazing job of making sure the public knows. But when we think about it, in many ways, kidney failure has a higher death rate than certain types of cancer. But people don't have that same, oh my God, reaction. And so really, again, speaking to communities to talk about, well, almost everyone in certain communities knows at least one person on dialysis. And what they don't know is that their life expectancy and quality of life have been greatly diminished. And when they find out, they often say, well, what can I do? Even if it means that they then start to approach the patients themselves. And so these are just some of the types of things that we've tried to do to try and be respectful of people's concerns, but also trying to highlight things for them that they may not truly be aware of in terms of helping them to move forward.
Well, thank you very much. I think these are questions and ideas that will need to be continued at the end, and hopefully we can have some shared understanding about these issues. In the meanwhile, we will continue with the presentations, and I will ask Dr. Amit Garg to start this presentation. And I just remind everybody, if you have questions, and I'm pretty sure there are many thoughts and questions that come to mind, please submit them to slido.com using the code of AM1A. And Dr. Garg, please start your talk.
Well, hi, good morning. Just wanted to make sure I'm getting access here. Just 1 second. Sorry. Okay. Good morning. So I really want to thank the organizers for this opportunity to participate in this excellent session and for their hosting of an entire week focusing on living donor transplant and the opportunity to speak today. In terms of being thankful, I'm also thankful that it's a great day here in London, Ontario. Today's the first day of school. Part of the back of my mind, I'm worried that kids who are at home doing homeschooling are now suddenly going to flood the internet and my bandwidth might go down. I have 3 bars right now. I think I'm okay. but if that does happen during this presentation, I'll come back on quickly. So the focus of this talk particularly is equitable access to living kidney donor transplant. I've taken the position in Ontario. As you heard, I currently have the fortune to be serving in a medical lead role for the Ontarian Network, trying to work with partners to increase access to transplant living donations. So in that context, the focus is Ontario, but I'll have some general Canadian comments as well. In terms of land acknowledgement, I want to acknowledge that I'm calling from London, Ontario, which is the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, Muck, and Adano-Woronaran peoples, and that's where I'm calling from. And in terms of disclosures, some of the work I've been involved with has been funded by the federal government, with strong support also from Astellas and partnership funds. So for the audience, which I suspect is mainly Canadian, but for our international delegates, here's Ontario. We have about 13 million citizens. 16,000 patients are cared for in advanced chronic kidney disease clinics, sometimes referred to as multi-care kidney clinics. Approximately 11,000 patients on dialysis. We have about 1,100 patients on the kidney transplant waiting list. And unfortunately, over the last decade, we've noticed that the living kidney donor transplant rate has been stagnant at about 220 living donor transplants per year. That's 17 per million. And so the organizations involved in improving access to kidney transplant and living donation, that Trillium Gift of Life and Ontario Renal Network, thought something should be done about this, and particularly to try to improve the status quo. And really, we want to see an annual increase in the rate of living kidney donor transplants in Ontario. The stagnation in Ontario is also common across Canada, and it's not specific to Canada. It's also occurring in many countries. And so we have a strategy right now that we're enacting. It's a quality improvement intervention to enable access to kidney transplant and living kidney donation in patients with chronic kidney disease, ENACT LKD. And in terms of the evaluation of the strategy, it's a 2-arm parallel group, open label, registry-based, cluster randomized clinical trial. And so to orientate you again, I mentioned the number of people with advanced chronic kidney disease or who are receiving dialysis in Ontario, and approximately 10,000 have no recorded contraindication to kidney transplantation. When we look at the large healthcare data sources, we don't have any specific information if they have a correctable cardiac disease, those types of things, but we have some, possible absolute contraindications, like they're on home oxygen, or perhaps they're in a nursing home, or they have a profile where no one in Ontario has ever received a transplant. And so when you apply those exclusions, we have about approximately 10,000 people. And so in terms of our strategy, we randomly allocated half the CKD programs. The care for these patients is organized across 26, now 27 CKD programs. London is one program, Hamilton is another program, etc. To receive usual care, this quality improvement intervention, which is a multi-component strategy. The intervention began in November 2017. We originally planned to follow up to March 2021, which would be a 3.5-year period. But now that's been prolonged because of the COVID pandemic, where for approximately at least 3 months, we had very limited kidney transplant activity in the province. The focus of the intervention is to increase the rate of key steps completed towards receiving a kidney transplant. We've done a lot of work over the last several years trying to improve our data sources and quality of the data to track these things. So we want to see if this intervention increases the number of patients referred to a transplant center for evaluation. And just in terms of context, unlike other countries, particularly the US, here in Canada, most of the workup package is completed by the CKD program, and a complete package is then sent on to the transplant center, unlike other jurisdictions where someone who's interested in transplant gets referred to a transplant center and the package begins. So refer to a transplant center for evaluation. At least one living donor candidate contacts a transplant center for an intended recipient and completes our initial psychosocial questionnaire. A patient is added to the deceased donor transplant list, and a patient receives a kidney transplant. either from a living or deceased donor. We acknowledge the likelihood of increasing deceased donor transplant is probably pretty limited, given the median wait time in Ontario for deceased donor transplant is about 4 years. And so really the focus is living donor transplants. And the historic information pre-2017 is not perfect, but for what it is, it suggests that there are about 22 steps per 100 patient time years completed historically. So if that continues in the usual care group, we would have 80% statistical power to detect 12 more steps. So if the rate increased by 12 more steps, we'd be able to detect it. This intervention has required a number of considerations, which I won't discuss today. And just to give you now some information on the multi-component strategy, which will be germane to when we now try to potentially tailor it to addressing disparities. There are different components of it that are led by different people in the province. I want to acknowledge Dr. Seychelles Johanna, who's provided expertise in quality improvement, Dr. Kyla Naylor in data analytics, and Ms. Sue McKenzie is a transplant recipient who's developed a pretty profound transplant ambassador program, and Dr. Esteban Mutsi, who's provided leadership in the educational aspects of this strategy. And the strategy really has 4 main components. We have local quality improvement teams, which we've enabled, that has key representations from quality improvement experts and leadership, and also patients and providers. Administrative support that's provided centrally from the province, at least 3 full-time FTE are supporting the entire strategy. We have tailored education resources for staff, patients, and living kidney donor candidates. There's a robust transplant ambassador program, as I mentioned, to support where there's support from prior kidney transplant recipients and living donors who can interact now with people who are in their shoes but are going through the process. And also there's accountability, there's program level reports and oversight by program leaders. Dr. Purnell alluded to this, but when we think about health, in terms of the World Health Organization and the dimensions of quality care, one thing we're focused on being effective. And one of the realities of doing evaluations, rigorous evaluations like clinical trials, is you often only have statistical power to look at the overall effect. And so we're looking overall, is this strategy effective? But the focus today is also, is anything we do to improve access equitable? That is, delivering healthcare which does not vary in quality because of personal characteristics such as gender, race, ethnicity, geographical location, or socioeconomic status. And so now let's look at this entire initiative and or future initiatives that we want to launch in Ontario and Canada from that lens. So how can current and future iterations of the strategy reduce barriers which result in equitable access? That's one of the questions I think we all, as people who practice in Ontario, are thinking about. And through initiatives like the one today, we can work together to develop our strategies to address this. And Dr. Purnell also had this nice slide where she described different levels of where these barriers occur. This is not from the lens of disparities, but you can easily start applying it. But when you think about access to transplant, the barriers are at the patient level, the donor level, the healthcare provider level, and the healthcare system level. And for patients, it's knowledge, supports, motivation, logistics, communication. And when you start putting the lens now of equity, it's also trust, as you heard from today from Dr. Radwana, about cultural appropriate support and knowledge, etc., and even communicating appropriately. There's religious context you heard as well. And for the donor candidates, there's similar types of barriers: awareness, knowledge, communication, logistics, cost. Healthcare providers have challenges around the time they have, the records they keep, the accountability they may have to the entire system, and their knowledge. And from a healthcare system perspective, we have considerations around funding, coordination, and accountability. And so which disparities could we think about? So there can be rich work done in Ontario, Canada, and worldwide, focused on understanding these disparities by interacting with patients in patient-oriented studies, et cetera. From a system level, if we want to do something simple, we do have data on these characteristics. And I'm going to give a caveat to that in a moment, but there are, for example, information in which we've used in several prior studies, not only in this space, but in many other spaces around geography, both as a crow's flies, or if you even want to calculate by road distance, how close people are to renal programs, to transplant centers, et cetera. Socioeconomic status, we have information at the neighborhood level. So income quintile, marginalization indexes, ethnic concentration, et cetera. These are some of the characteristics we have there. We do have a sex as organized, as described on the provincial health card. We do have some race information. Ontario Renal Network in the Ontario Renal Reporting System does collect self-reported race. Some of it is absent. And also there is information on First Nation status, which is managed by the Chiefs of Ontario, where there's a steward that can help support this data. The data that I'm referring to here is held at the Institute for Clinical Evaluative Sciences. Some of you may be familiar with it. It has about 80 or 90 linked data sets. Disparities we're not talking about today are things like age, obesity, et cetera. And this is not a new topic. I was one of a few Canadians who participated in this US Consensus Conference in June 2014, where they were trying to advance leading practices in living kidney donation. And this was led by several colleagues, including Jim Rodrigue, who's a prominent person in this space. And in that conference, one of the reports that came out was overcoming disparities in live kidney donation in the US. And if you look at the 4 key recommendations, they apply again today. Remove financial disincentives to living kidney donation. Implement culturally tailored, community-based living kidney donor transplant, living kidney donor educational programming at multiple stages of the transplant referral process. And I see this being encompassing everything from public awareness. We have like public education awareness around deceased donor transplantation, but really we still lack a really cohesive, prominent approach to living kidney donor transplant awareness. There's cultural safety training and other training for health professionals that operate in these spaces. There's education towards patients and their families, et cetera. It's all aspects of this thing, and including faith-based considerations. They also recommended engaging a transplant liaison who had this expertise in community nephrology practice and dialysis clinics, and develop a research strategy to better understand the disparities and address them. And Dr. Purnell alluded to this, and I just wanted to give this also some attention. We have to be very careful when we use these labels. When we talk about any of these labels I just described, they're so, it's hard to put like sometimes words to something that is so complex, several of these issues. And there's a dialogue occurring about many of these things in society today. For example, even when any of us do research now, we almost all applications now have to describe sex, gender-based analyses. And if you go through that training, like I am and several others done, it's quite complex. Are you talking about like biological considerations? Are you talking about socially constructed roles, et cetera? And in terms of race, there's a dialogue going on, even like very fundamental things like how we assess kidney function. This estimating glomerular filtration rate, which has a Black race term within it, is now coming into question about what the appropriateness of that is. There are very important considerations around First Nations and Indigenous peoples in Canada and how that intersects with what we're discussing today. And also a lot of these things aren't in isolation. When we talk about geography, that also can overlap with, First Nation status. And when you talk about several other of these things, they overlap. So when I present the next few slides, I'm overly simplifying many of the deep concepts that are here. So let's first focus on geography. So what do we know in Canada? There's been very nice leadership work done by colleagues in Alberta. This is Cello Tonelli and John Gill and others' work, where they first looked at the US citizen, and they, at least in one prominent study, they said remote or rural access versus urban residence was not associated with the time to receive a living kidney donor transplant. Canada is a much bigger country, larger distance to travel. And when we look at the Canadian data that they've also published, that distance was associated with a lower chance of receiving a living kidney donor transplant in non-white Canadian children. Dr. Samuels published that, but not associated with the likelihood of receiving a transplant when both living and deceased donor transplant were combined. We heard in Dr. Purnell's talk about the challenges that COVID is presenting, but now when we think about solutions provincially, the teleconsults that we've now been used to doing is actually creating an opportunity, isn't it? Particularly when it comes to geography. I'm originally born and raised in Sudbury, and when you go travel in my current role to our northern communities, one of the difficulties they have is having their patients and families come down south for their evaluations and staying here, both pre-donation and post-donation. And I personally have now become much more comfortable as a nephrologist who does living kidney donor evaluations, delivering those through telemedicine. I don't like it when I don't see the person, so that's very important to me. But I've now gotten very used to this, and so I see this now extending in the coming years to evaluating living kidney donors in places who have geographical barriers. Our social worker also feels comfortable doing this. When I talk to our surgeons, they are less comfortable. They still want to see the patient beforehand, but many patients, unless they have intra-abdominal considerations, can be kept later in their evaluation phase to see the surgeon. So that's also still an opportunity here. So overall, I've been pleasantly surprised at how COVID has made us now do these evaluations online for telemedicine, and that I think is working really well. And I see that there's an opportunity there to extend that, and including intended recipient evaluations as well in many aspects. The other thing I wanted to highlight now in terms of accountability, if we're trying to address disparities, I talked about geography, but this could apply to any disparity. This is an example of a report that goes to each chronic kidney disease program approximately every 4 months. So now, unlike before, we give a program reports on how well they're doing in helping their patients access kidney transplant. We give them things like, how many preemptive kidney transplants have you done in this quarter? So to orientate you, here are some measures: living donor transplants, deceased donor transplants, total kidney transplants. And I don't have another slide, but we also look at how much education they receive, et cetera, et cetera. And we say per quarter, here are the quarters, how have you been done in this regard? So all the programs are starting to receive that, and have been receiving it for several years. But what you could do, and this is the opportunity perhaps for the discussion period, is you could start now presenting some of the disparities in these reports. This would be not something to be done lightly, but you could show like how people of a certain, some disparity characteristic, acknowledging all the limitations of these labels, and have access to transplant. Now, this has been done in other, and is being done in other settings. This is some nice work done by Dr. Rachel Pasner, who's done a lot of leading work in access to kidney transplant. And they have an ASCENT trial going on, allocation system changes for equity in kidney transplant, which has many components, of which one of the components is a dialysis facility-based performance feedback report. When I was looking at this online, like the reports now have like some racial information on it. So that the unit doesn't only see the results overall, but see it now based on how patients of certain race in their units are doing. And that's something we could consider in the Ontario context in our reports. Also, to address these disparities, I think extra emphasis on transplant center outreach, education, and support is particularly important. This has to happen all the time, but particularly important for sites that are geographically far away. And then also the reduction in financial risk we've heard, and particularly for people from far away, travel and accommodation costs are a consideration. And so that kind of gets into the next stage of the socioeconomic. We know there's a health wealth gradient in many aspects of medicine, and wouldn't surprise you, I think, to find that it occurs also in this context here, both in Canada and abroad. And reducing, like, we can't address this entirely, but reducing the costs incurred by going through the process is something we can do. And then so just to orientate you, there's costs borne by the recipient and the donor. When we look at the donor's costs, the donor candidate's costs, they have to go through many aspects of a process, don't they? Where they get evaluated, go through testing, come down to the transplant center, ultimately donate or offer a few days, back to full function in 6 weeks. And so they incur costs of travel and accommodation, lost income, dependent care, some post-discharge medication and support persons. So over the last 15 years, we've been working in this space trying to quantify these costs and advocating for sound reimbursement programs. And when we've quantified some of these costs in the Canadian setting, 15% of donors were incurring over $8,000 of Canadian expenses. And donors that did incur higher expenses, at least post-donation, were demonstrating higher anxiety and lower quality of life. The development of reimbursement programs that are present in Ontario, like the preload program from TGLN and other programs across the country, have certainly been a welcome addition. When we've looked at now the gap that still some patients face, even when those programs exist, there is still a gap. So there's an opportunity further to tweak these programs to really make sure donors are not disadvantaged to the process, and similarly, recipients are not disadvantaged to the process and the cost they incur. This will not by any means address all the disparity when it comes to health and wealth, but certainly is one positive step forward. When we look at sex/gender, my interpretation of the literature is generally the rates of living kidney donor transplants are similar in men and women, but the chance of becoming a living kidney donor is much higher in women versus men, in mothers compared to fathers, and in wives compared to husbands. The considerations in this space is that treated kidney failure is more common in men versus women. Perhaps some of the contraindications to donation are more prominent in men versus women, but that's not always consistent. As someone who evaluates living donors, often when we see benign asymptomatic microscopic hematuria, we see that more commonly in women. And that also sometimes complicates the evaluation process. Female recipients may be sensitized from prior pregnancies, and there's a body of literature to support that kidney pair donation has helped reduce that issue to some degree in terms of access. There are, of course, social and cultural reasons that underpin all this, and even possibly the amount of altruism that different people have. There are employment and financial considerations for donors. So if there is a large financial loss from an income earner, that could possibly be playing a role in this space. Now, you heard from Dr. Purnell this concept also, like who's willing to put their health out there in their request for living donor. And in fact, there is some literature in this space that suggests that although we see some differences in who becomes a living donor, in terms of men and women, there's, again, literature suggests that women are more likely to be more sharing of their health considerations and need compared to men. Also, I'm mindful that when we talk about living donation and we're trying to increase living donation, we're part of a system where we're also subjecting donors to risk. And There will be some donors who have these poor outcomes post-donation. That will happen. We want those to be minimal. When they do occur, we want to make sure we're practicing in a system where we were very responsible around this entire practice, so that when we do have these events, at the end of the day, we feel still we've been doing the right thing as people enabling this. And so some of the risks, particularly to women, as you know, are pregnancy-related risks if they donate early. There's also some information on psychosocial risks post-donation, fatigue and mental health related quality of life that suggests, based on the labels again of men and women in those studies, that there was differences between the two groups. So what are the solutions here? This is not comprehensive by any means, but should our education materials be representative? In preparation of this talk, started looking at all the materials we created for the Ontario setting, and the ones that we curated and present on our government websites. And how many times are different types of men and women being presented even visually on these materials? That got me thinking. I started looking at that quite carefully. You could create specific education materials that address this issue if we felt that that was important and specifically focused on this. I think there's a real opportunity for all these disparities to engage social work much more in CKD programs. In truth, my perception has been social work in our programs, not on the transit, on the CKD programs, haven't been as involved in much in this space as they could be. It's a part because they're also have so many competing demands. But some of these working with families and discussing and addressing these disparities, I feel they have a very important role to play. And that's an opportunity, I think. And again, financial support may help some of the considerations on employment barriers. And so here's just an example of some of the information materials. I talked about education materials, but even when we talk about support, like our transplant ambassador program, that's nicely patient-led. When I look at the materials there, like, is it presenting all these disparities in the right way? So you have representative individuals from all aspects so that people can relate to it. I knew race was being discussed in the other two talks, so I don't really spend much time on this, but I know there are many active interventions to address racial barriers in living kidney donor transplant. I'm most aware of several ongoing initiatives in the US, including web modules and communication and financial barriers that are ethnic-centric to address disparities. The one published report that many of us are very familiar with is this nice study by Rachel Pasner. Was published in JASN in 2016. It's called the Radiant Trial. And the motivation here was, when I talked to her, is that in Georgia, it had some of the lowest rates of transplant in the United States. And so there was a strong impetus to want to do something. The rainbow part of the slide here presents the different aspects of their multi-component strategy. This ran in 134 dialysis centers in Georgia. And baseline, about 11% of patients were referred for transplant evaluation the year after dialysis initiation. And the intervention resulted in a 6% increase in this referral after the start. And it seemed to be differentially better in reducing disparities. This is one of the main goals, to reduce disparities in access amongst Black compared to white patients. But again, you again heard from Dr. Purnell, when you have intended recipients ask when their younger family members, including their children, are going to be accessing transplant, and particularly becoming living kidney donors, there is this tension because we know that the risks potentially are not also the same across all different ethnic groups. Again, saying with all the caveats that ethnic group is a very blanket statement. It has to be much more precise than that. Is it, for example, in in Black Americans is related to APOL, A1, et cetera. So all that notwithstanding, this is a study we did as a part of our work in doing the KDIGO International Clinical Practice Guidelines on living kidney donation. And we tried to project the risk to the living donor candidate in terms of their development of end-stage kidney disease. And there's several now other calculators that do this. This is one example of this. And you see that the estimates show, unfortunately, that, again, using these labels of Black and white in the US data, young Black men particularly, in terms of living donors, had the highest absolute lifetime chance projected of end-stage renal disease. So not everyone might have the same safety profiles around becoming a donor, and that complicates this entire situation. The other area, finally, in terms of race that we in Canada need to address is the issues around Indigenous peoples and First Nations, Inuit, and Métis peoples and their access to kidney transplantation. There's been some nice work, again, done by colleagues in Alberta, Brenda Hemmelgarn and Cheltenham, that show quite clearly that there's less access to kidney transplantation amongst First Nations individuals in Canada. There actually is a large initiative being undertaken in BC, being led by Jag Gill, to try to address some of these concerns in a federal government-funded study. Whenever you work in this space, you have to, the members have to all undertake appropriate training and sensitivity and cultural awareness. There's issues, something called OCAP, ownership, possession, access, and control considerations around the data and who owns it. And so in Ontario, we've been having a dialogue with the Chiefs of Ontario now for 2 years. And when I say we, this includes a partnership of several people, including patients of First Nations background who have kidney disease, administrators, et cetera, trying to advance a strategy where we can use the data source we have to give better insight into the disparities faced, and then ideally develop solutions to address it. And again, we have this consideration then about the risks. Whenever we evaluate people with kidney failure who have a First Nations background, and then they have living donors come forward, the study from Manitoba by Dr. Leroy Storsley and colleagues does catch our attention, where 18 years after donation, the risks of hypertension and diabetes in First Nation donors was substantially higher than Caucasian donors. Again, this issue, this complex issue where the risks to the donors also may differ by race, ethnicity, and how do we account for that in this consideration? We're trying to enable and enhance access to living kidney donor transplant. So I think I'm out of time, but I just wanted to raise some of the considerations around how we want to take, I think, a full system level consideration and approach that future iterations and current iterations of any strategies to improve access in Ontario or Canada addresses the barriers which result in equitable access. And with this, hopefully, the bottom line is we'll help more of our patients receive living kidney donor transplants and the benefits those entail. Thank you very much.
Thank you very much, Amit, for this presentation. And I think it, again, provided a lot of information, a lot of relevant information to the discussions, both before and what's coming. And I just wanted to, again, provide some plug-in for the upcoming sessions of this Living Donation Week. As all of the previous talks presented and illustrated, this is a very complex area, very difficult tasks ahead of us. And this is why the Center for Living Organ Donation at UHN dedicated a whole week for these events. We will have actually a specific session designed and dedicated to Indigenous issues that is coming up Friday morning. And many of the initiatives you mentioned and others will be discussed there. And I think it is quite essential for various reasons. And we also have another session coming up towards the end of the week, Thursday, about where we include the perspectives of various faith communities, because as both Gertch and Tanyala brought that up, it is essential for many of the communities that experience different barriers, and involving faith communities and faith leaders may be one way to potentially reduce the barriers. And certainly there are successful and efficient initiatives within several faith communities that are able to address some of the issues brought up. And finally, just the final plug-in for the upcoming session at 11:10 today, which will discuss our ongoing government-based or government-funded initiative to assess barriers and reduce barriers both in South Asian and the African American and Black communities in Canada. And that might be something that both can inform some of the audience that are present today, and also can learn from many of the thoughts of the current speakers. So hopefully that will be another session that can bring together a lot of thoughts. Before going back, I know it's a bit late, but there might be a comment that was sent in. Courtney, is that something that you want to read it now?
Sure, yeah, it was just a comment for Dr. Purnell. So thank you very much, Dr. Purnell, for that empowering talk. I really appreciated how you highlighted the impacts of systemic racism and the COVID-19 pandemic on access to healthcare and kidney transplant specifically.
Oh, wow. Thank you. I genuinely appreciate all of your support, all of your help. As I stated previously, this is a difficult time for all of us. I think if we learn nothing else, we have to learn that it's important to call out the truth at all times, and to speak our truth, and to listen when others share their truths, so that we can really build a better world. So thank you for your kind comments.
Yeah, thank you very much. So we will be moving on. If you have additional comments and questions, please submit through slido.com using the code AM1A. And I'm pretty sure that the next speaker will also motivate a lot of thoughts. As you remember from the initial introduction, the next and last speaker in this session will be Dr. Amy Waterman from UCLA, who will also bring a systemic perspective, but something that can be combined on an individual action level. Thank you very much for your time, Amy, please.
Thank you. Thank you. Can you hear me okay?
Yes.
Great. I am so happy to be here. The sun is rising in Los Angeles. I'm unable to leave the home due to fires, so you can't go outside, and inside due to COVID. So I'm happy to be sharing with the community. So let me make sure I can drive. All right, great. I also wanted to, 1 second, sorry. If you could back it up, Matt, 1 second. So I just want to also say that I'm here representing UCLA and the Terasaki Research Institute. And I will never be touching these people again. That's what I think, but we are still working for the good of this cause. Okay, so we know living donor transplant rates are declining in Canada. We're concerned that they're going to decline after COVID in the US. That data is still coming in. But we also know that the disparities continue to be true, no matter what we're all doing, okay? And I have had the honor of working with Dr. Mushi for years. I've also had the honor of speaking at the center, and I really admire what's happening. And I think no matter who's speaking, whether it's me or other researchers in the US or anywhere, it feels like we're all approaching this challenge of how do we support and increase living donation from a multi-level perspective. So I think about this like an onion. You have the patient in the center. I need a kidney. I would love to live longer. I would be open potentially to a living donor. But then you have these series of slices of the onion, the potential living donors, the support network, the family and friends who are supporting both of those, the providers, the organization, and the community. And I think what Tangela really highlighted is the external parts of this onion have just changed with COVID. So we were in a system that was difficult before, but now we have community challenges that have risen and been made worse. So the other piece I want to say, though, that I think is even more sensitive, and I've started to think about this in a different way, is that I think the onion's two parts. I think you've got the onion for the patient, but I think you have the same multi-level challenges for the donor. And often we say, well, the patient just needs to handle what they need to do on their side, and then the donor will just come forward, right? But as we're seeing, potential living donors are in our community, are facing every level of challenge, are making different decisions. And the work on living donors is potentially a little less advanced in some different ways, because we have a lot more ability to talk to the patient in our transplant centers than the donors. So if we say, okay, how do we increase the number of living donors, especially from diverse communities? It's a great question. People have been studying it. And I want to say we could possibly do it in two ways, okay? So how do we find more potential donors out of transplant centers? So this is important. We need to extend our reach. We need to be changing messaging, public health messaging, culturally tailored messaging, all of these things I know that different groups are doing. And that's been exciting. One of the initiatives I spoke at the center last year on was the Living Donation Storytelling Project, which is available to explore livingdonation.org. This is a program where you can meet people who look like you, who have gone through this, who have information to impart. So it's about like making living donation normalized. That's people do it, and people who look normal, not a perfectly made up person, right? But just an average good person who is in the world. But I want to shift now for this talk to talk about the second part. How do we help more potential donors who begin evaluation actually donate? And this is a really interesting thing, because these people are all initially expressing interest in this, and there's variability. So I run the Transplant Research and Education Center at UCLA, and the purpose of this center is to understand and overcome the critical modifiable barriers affecting transplant rates and outcomes. And the key word that I love is modifiable. One of the pieces that I feel when we talk about reducing disparities in access is often we say, well, they're racial disparities or they're socioeconomic disparities. And now we know that. So where I'm looking is, where can we move the needle? What is it that we can do something about? How do we not give up, right, as a community? And I want to talk about a model of a way to think about this that I started doing in 2013 with a paper that I published. So we looked at the other half of the onion, the patients. So we measured patients walking in the door who were white and African-American, because I was living in St. Louis at the time, and 700 people. And then we followed them till they were finished. And we asked them questions about all sorts of things. Things that were fixed or less modifiable, like demographics and comprehensiveness of healthcare coverage. But then as you move to the middle and the end, you start to see some of the other things. There could be interventions that are planned, ways of interacting, overcoming practical barriers that could make a difference. And maybe there's something that we can do that would matter. And what we found when we did this study, you can go and read the paper if you'd like, but the piece to me that was exciting at the time is that we found that people who walked in the door on day one more ready to pursue living donation and with better knowledge ultimately became got a living donor transplant. They came in more prepared, they came in more knowledgeable. Now, this launched 1,000 ships, and one of them Emmett just talked about ENACT, where we really said, okay, we need to prepare people better, right? So they're walking in the door, and Dr. Mucci and I have been working together in terms of the ENACT intervention that you were talking about to make sure through education into the Transplant Ambassadors Program that people are having what they need so when they begin, in hopes that this will increase living donations. So I wasn't the cause of the ENACT intervention. I was just one of the papers used to design it, but I want to acknowledge everything that's happening in Ontario, because to have a multi-level intervention that's touching many different things that includes this is really exciting. So what affects potential donors' behavior? We play the same game of less and more. So yes, the same kind of less, the things that we can't do a lot about, that we talk a lot about, are socio-demographic factors, medical contraindications, who they're donating to. It's interesting, spirituality, maybe you can change spirituality. We can talk about that. And it's interesting that what goes in the middle, right? So people say, can you change medical mistrust? Is it a fixed thing? Health insurance status, caregiver, access to transplantation, health literacy. And then as you move over to the more, you have, what are they doing to prepare? What is their knowledge? What actions are they taking ahead of coming to a transplant center? What costs are they incurring? So you can see, like, again, same model. We have to really carefully choose where these things fit along a continuum, but we could definitely study them. So I was able to get a grant in partnership with St. Barnabas through the National Institute on Minority Health and Health Disparities. And this has been a labor of love. It's been really hard to do because we approached this in a way that other people didn't. I also want to thank all of these different transplant centers who partnered with me to collect data, because the big issue is we do not have a lot. We need a large data set of potential living donors of various races and ethnicities so that we can watch what's happening. It's not, we can't just say 100 people went through. So what we did was we said, okay, we want to study people on many levels of things, and we want to look at their, we want to see where they are when they start, and we want to see ultimately who ends up donating, right? So we want to follow them over time. And what we found in this data set that I have now is we have 2,576 potential living donors. And this is the part to me that's exciting. These are people who came to the center for whatever reason, were touched by the cause. We have someone in need of a transplant. And at the end of the day, they either, there's probably three outcomes. They either were medically ruled out as not healthy enough to be able to donate. They themselves chose not to continue, or they donated, right? So the thing that's really interesting, if you just stop and look at this for a second, is that, wow, there are a lot of good people who came forward in these centers, and wow, few of them actually get to the finish line. So it's important to really understand whether we're part of the problem, whether there are things we can do to better support people who can't continue due to challenges that they're facing. This is where I'm looking as a modifiable factors person. So the thing I also want you to know is we worked extremely hard to capture potential donors who are the races of the United States that are common. It was really, we were so excited to have people to be able to compare and look at these kind of issues. So let me just show you some data to get you thinking. So we've been talking about these challenges. We've been feeling like, you know, this is, we're up against, you know, an unmovable rock here. And I'm like, let's look where we can move the rock. Let's be hopeful. That's me. I stand in hope. I actually got a mask and I had them embroider hope on the side of the mask. So I wear that around now. But the thing I want to say is, this is fascinating. Okay, who did these people, these potential living donors, come in to support? And what you can see is, first of all, everyone. They came in to support all sorts of different people. But then if you look at the larger bars that are at the top, the white bar, the Asian bar, and the black bar, you can see that the white patients were more likely to come in for a friend or an acquaintance. Then you have the blue bar. The Asian individuals came in for their spouse. Black patients were more likely to come in for their parent. So that's a really interesting thing. I think we could even get more data to see, but if we're seeing that there's a pull for certain communities to come forward, what does this mean? We can talk about it afterwards. Okay, so let's talk about preparedness to donate. People spent time beforehand educating themselves about living donation. And if you look, first, let's just look down the all column. You have people who are reading brochures and websites. You can see talking to people that they trust about the risks and benefits, talking to medical professionals, and thinking through their family and work responsibilities. I'd like these numbers to be higher. It's hard that if you know 70% or less of the people are not doing these things, we got a lot of work to do at the center, and there could be people who are discover things at the center that aren't right. You see that white patients are more likely to be doing these things. Black patients are significantly less likely. All of the circles are showing the significant differences. To go to knowledge, same thing. This is interesting. We at the pre-time, we didn't want to quiz them yet. We just wanted to see their perception of their own knowledge. So we quizzed them later in the survey process. But we said, how much do you feel that you know enough about expected recovery, about risks, about tests, and about what donation-related costs that I may have? And what you can see here is they're feeling pretty good. They are scared. They know less about the costs in general, the people walking in the door of these 6 different centers. And we find that Asians feel that they know more, and Black patients feel that they know significantly less. Okay, so motivation. Why did they walk in the door? I love this. And there's many reasons why somebody wants to do something. This is interesting. First of all, the beautiful thing I want to say is that no matter what race you are, you come in because you want to help someone live longer. You want to help make someone's life better. And you want to believe that this will actually help everybody, the whole family. That's beautiful. No differences, irrespective of race. This is just why they're walking in the door. Now, the interesting thing, if you look at the bottom though, the donation will make me feel proud of myself. There's most people say, no, that's not why I'm motivated. There's a higher likelihood though of Asian and Black patients feeling good, that this makes them feel proud. And I think this is important if you're sending messages to these communities, that there is a reason that they're coming forward. It'd be fun to explore why they're feeling differently than others. The other part is spirituality. So, you know, they talk about how blood donors, people in the military, and people who are from faith-based communities or have a spirituality are more likely to come forward. We saw this in our data that, and we saw this more commonly in the non-white communities, that people from these communities, they were talked about how important religion and spirituality is important in their lives, more likely to believe in God or a universal spirit, and believe that their personal or spiritual beliefs suggest that they should be helping others. Again, a place where you guys, what we're saying about faith-based communities, I think that definitely this is a way to go in terms of intervening. All right, resistance to donation. So 10% of the donors wish their recipient would get a transplant from someone else. Just to pause on this, these are the people coming into the transplant center being enrolled into being a potential donor. So I want to be sensitive as a person who leads education efforts within a transplant center. There are people that are there that potentially are coming in due to family pressure, due to worrying, with a lot of anxiety. So it's interesting to know that 10% of the sample was there. And more likely to be, of the people who would like to pass on this opportunity, more likely to be Asian, less likely to be Black. And what we found though, that this is fascinating. So the other part is we said, okay, do you have someone important in your life that doesn't want you to donate? So this goes to social support, it goes to, you know, advocacy and in the home. We have, again, 10 to 17% of racial communities are saying, yes, I have somebody important in my life that doesn't want me to do this. So then you go to financial risks. Okay, so what we have in America are these things. We have almost 90% do have a financial impact from donating. On average, $5,000 in donation-related costs. You might lose a month of household income. 1 in 5 lack insurance to cover the costs. So we've got in the United States a big issue with financial challenges due to donation. And again, non-white donors and donors with low income and low education levels are more impacted by these. And then you add COVID on top of this. So this is where I think it's really interesting and how this all comes together. So you have, so these are the kind of common data that non-white potential donors are more likely in our sample to report basically financial stability for only 3 months, no insurance, lower incomes, and lower education. And again, that's a non-modifiable thing unless they can get a different job. That's not something for the transplant center to intervene with anyway, but this is where I think it's fascinating. So remember the question where we said potential donors reported that they wish somebody else would donate, right? 10% with variation by race. If you cross this with race and concerns about incurring donation costs and incurring loss of income over time, this is a big issue here for certain communities. And overall, almost 20% for our patients. So I think this is actually something you all can handle differently than we handle in the United States, but it's really critical because the unwilling people, the people who might drop out, are people who are facing concerns about this. And it's more common in the Asian community. Okay, so I have been collecting data for 5 years, and I've been dying to see who actually donated of all the people that we saw at the beginning. So we're beginning to explore this, but let me show you the feel of it. So who ended up donating? So, and what were their races? So this is a little different in the percentages, but of the people who came forward, we did have people who ended up donating that were of all races. And one of the things I'm asked commonly as a transplant professional is, well, you know, there's no donors who are all of these races. They face higher risk of the disease anyway. There's no one who's going to come forward. So I really feel there's a message to be made in our community that good people of all races and ethnicities donate all the time. And we see this here. Now, of each of these groups, so we have more white people donating, sure, but we have everybody. But then if you look at how of the people who started of each race, who actually finished, you see between 10 and 20% of people ended up donating depending on the different race. More females, more educated, and more financially well off, as other studies have shown. We're going to do a lot of modeling of this at a higher level, but I want to show you some of the interesting things. So of the people who walked in the door perceiving that their knowledge about living donation was acceptable, the people with higher knowledge were more likely to donate. In terms of people who were motivated, remember we talked about, do people in their community support them in donating? People who agreed that they had people supporting them in their community were more likely to donate. Okay, remember we talked about the financial risk? The people who disagreed that the possibility of having to pay for some donation-related costs makes it hard for me to donate, and taking time off work for testing and surgery were more likely to donate. Okay, so I want to stop there to allow for dialogue about this, but the feeling to me here is we need to still look at the people who stopped because they were medically ineligible against these other two, this collapsed this, and we're going to look at this as a, in terms of regression. But I see a few key conclusions. First, 10 to 20% of potential donors of different races actually became donors. And it wasn't that the white community was more likely to have more of those people. You had this amount across all of the different racial groups. While different racial and ethnic individuals volunteer for different types of people in their family and friend communities, all came forward to help improve someone's health and life. But there's a lot of variability between racial groups and how much they know and are prepared to be a donor, how well they're supported by others in their community, the importance of spirituality as influencing motivation to donate, and their concerns about costs and impact of donation. So going back to what might move the needle. So let's think about, where do we go in? So years ago, we said education and knowledge for recipients. We're seeing the same thing for donors. Preparing and educating potential donors better is a way through that is showing differences in donation. Ensuring family and community support for donors. If that's not there, how are they going to get to the center? How are they going to face the recovery? How are they going to face the financial impact on the family if there's no support internally? And finally, how do we make sure the costs are as minimal as possible? Great. I'll take time for questions.
Thank you very much. It was an excellent talk, very relevant, timely, interesting new data. And I guess more to come there. And I think there's a lot of things to discuss. So I invite Tanyala, Gorch, Amit back to the table, the virtual table that we have. It's a transatlantic table that we have, which is great to have. And we may actually try to continue this transatlantic table, because although many of you emphasize the importance of local initiative, I think it is also important for us to realize that there are some common themes here, and maybe combining the approaches and the knowledges, looking at the differences and looking at the commonalities may help the advance the needle. So I think it has been, certainly I learned a lot, and it has been an excellent experience to listen to the speakers. And we have a number of questions, and I will ask Courtney to read out the questions, and I will have some additional questions at the end if we have time, but if not, then we'll continue the discussion at a different location. And just want to point out, I keep on plugging this next session, which is on the ACTION project that looks at South Asian and Black patients and communities in Canada. If you have the time and interest, please log back in on a different Zoom account, and I'll let Courtney ask the questions.
Sure, thank you. So our first question here is, what is the biggest challenge in ensuring equity when it comes to living donor kidney transplantation?
So I guess maybe a quick round around. So who says which one is the big one, the one shot, or the kind of we can go in the
My answer would be all of them, like the multi-level factorial nature of this challenge. I don't feel there's a silver bullet. We all want there to be. We want there to be a single powerful intervention that'll clear this all out. I think it's about honoring the fact that this needs lots of levels of intervention at the same time. And if we aren't responsible for that, I think we're just naive.
Okay, so all of them, which is E in the multiple choice question. Gorge, Daniela, what's your take?
So to sort of follow up on Amy's comment about the fact that essentially all of these barriers, are challenges that we have to address. I think from my perspective, the broader real issue at the root of all of this is convincing the broader field and convincing the general public that this is not like promoting equity is not something that should fall on the burden of the few. That's not something that just a handful of people need to be committed to doing, meaning not just a handful of researchers or not just a handful of patients or communities. This is something that we need to realize is our responsibility and obligation as human beings to ensure that we address challenges that are being systematically experienced by subpopulations. And once we truly get the general public and the general broader community to understand that there's a role that we all have to play in this, then I think that getting all of those stakeholders to the table is the only way that we can truly address all of these multi-level barriers. So I think the biggest challenge is really convincing people that this is a problem that all of us have an obligation to tackle.
Thank you. Thank you. Gorge, how does that look from the UK?
Yeah, I mean, I'd agree with all of that. I guess the only thing I'd add is I think it's about saying that this should be business as usual. So if we're not doing equity, why are we here? And I guess, I think all the speakers have shown this in slightly different ways, but I think ultimately in the UK, we've always seen equity as an add-on, which, I mean, that's a failure of systems working when we see it as an add-on. And I think we've got to see this as being the foundations by which we do everything. And if we don't do that, I think we're failing in our duty.
Yeah, thank you. That's quite important. Amit, from you're kind of siding with Amy because you're putting pretty much everything in that quality improvement initiative. Do you have one favorite?
I'm not sure what a favorite, but in terms of the question, I'm still not sure what is exactly the thing that should be prioritized to be done first or given the most attention, and is it sustainable, and is it really effective? Like as someone who's involved with other partners to try to minimize this concern, let's say in Ontario. Okay, so one of my challenges after I review this space is, okay, what do we do next then? What is the really thing that we should invest time, money, energy, resources into that we know is going to give us the biggest bang? That's what I see as the biggest challenge.
I guess in a reflection of that, to what Gertz mentioned about the equity as business as usual, and I think it is an interesting and perhaps a more kind of general issue, but many of the medical students who come to medicine and many of the other health professionals come through vocation to this job with the aim of helping others. And it is interesting that the healthcare system that is being formed from the people who come with those true intentions will become a system which helps, or at least inadvertently maintain some of those structural biases and inequities. So I don't know whether that speaks to education and training in the healthcare system, whether that's the structure, the funding.
Yeah, I mean, I think there's also something about how do we decolonize the curriculum. So we have, I'm sure you have the same in many countries, but a lot of our clinical case studies tend to focus on mainly white Caucasian patients. So we don't tend to think about, for example, diabetes or kidney health in the context of diversity. So I think only if we have a culturally competent curriculum are we going to produce professionals who are going to be able to deal with this in a holistic way in the future. But then that's also incumbent upon us all as professionals, because we're part of the system that's delivering the current curriculum. So we've got to call it out. And there are power structures involved in calling these things out.
I'd like to add something if I could on this one. So one of the things that I feel, so we're also having a transformation in healthcare right now due to COVID, where telehealth has become the way to connect. And we always talk about the challenges of it, and we're definitely in transition at UCLA, but I see there's an opportunity here from an equity standpoint, because in the past, we could not have family come to a session. You know what I mean? There's a lot of like, okay, so my mom and dad are in St. Louis and I'm in LA and I need a kidney and they're never going to come. So there's a feeling right now of using this as an opportunity to build in better care for people, and potentially also patients are exhausted, families are exhausted coming to our center for 1 or 2 days of evaluation. So telehealth also gives the ability to not only engage a larger community, but second, to have the pieces of learning and the pieces of empowerment occur in different time points without causing a burden on them. And so I'm in a place of being hopeful. I'm like, let's use this moment of destruction and recreation of care to include equity decisions in it.
Yeah. Tanyala, do you have perspective on the virtualization of care? Is that going to help or potentially broaden disparities?
I think I side with Amy on this one and trying to be optimistic, because otherwise if we lose all hope, then, why even be here? But, and I think that truly it depends on the players. It depends on the system. It depends on the providers and whether or not they see this as an opportunity to rectify challenges for groups of people, whether or not they even recognize, what the barriers are. For example, if a barrier is, we all know that it's very exhausting for patients to have to keep coming in person. It's very hard at times for patients to start these conversations with their family members. But then we also need the other players across the board to know this, so that they can know that, okay, this is an opportunity for us to address some of these things, versus just solely focusing on what is of most importance at the time, I guess. So just the typical disease management and other things. And so I think that, it is truly an opportunity for us to, again, get everybody on board and understanding there's a role that we all should be playing, from primary care providers across the board. And once we do that, I think that we can truly maximize this experience to help to truly alleviate some of these barriers.
Just to add and also feed it back to many of the talks or many of the thoughts in the talks before, I think it is very important to do this, whatever change it's happening to the healthcare system, to do this together with the people who are affected with it or by it, because I think in the past and currently frequently what's happening, that things are created even with the best intention without really asking and relying on people who are going to use it, and that this is potentially exceptionally or especially important for culturally or financially disadvantaged and people who may have special needs in this change, and those needs may not be addressed if you don't ask them. Before just coming back to the theme, I want to read the Slido things here, and one comment is calling attention to the Kidney Foundation of Canada, which is available in the COVID period, and they have organized webinars and information sessions for patients and partners. They also run peer support networks, and they are a tremendous help for patients who need support with kidney disease. So we did not mention the Kidney Foundation here, but clearly there are services available through them, and they are present in this field. And the other point by someone who wanted to emphasize the need for mental health support. And again, we didn't really speak too much about the role of mental health, although I think in some of the talks it was mentioned that both donation and being on dialysis or having chronic kidney disease has a major impact on mental health and well-being. And certainly that is something that needs to be focused on and supporting both recipients and donors through this journey. I guess there is a critique here that UHN may not does enough, and I just wanted to mention that the Department of Psychiatry has a transplant psychiatry section at UHN, and also there are a number of initiatives trying to help patients with chronic kidney disease who have mental health issues and support them. There is a question here, how does the different health systems affect living donation? Okay, just in the US, health system is not free. Do less people donate because they have to pay for it? I guess that's for Tanyala and Amy.
Well, I can certainly start. First by, really, again, just directly addressing this issue of mental health. We know that there are very high rates of depression. There are also high rates of cognitive decline for people who have experienced kidney failure for a number of years. And we know that this often impacts other things like their abilities to manage complex conditions, or even, in terms of thinking about talking to others about something if you're already severely depressed. And so one of the things, that we really try to do, and this, I think also, I saw a question about reaching out to other organizations. I think it really would serve us well to understand that, just across the board, we may not be the best primary stakeholder for every single issue. It's important to recognize our strengths, our limitations, and it's important to really build sustained relationships with other groups that already have these existing relationships within communities. So, for example, NAMI is one of the national organizations in the United States that really focuses on mental health in, the general population and also in the severely ill. We also have local initiatives as well. So yes, we need additional support. We need better access to specialty care for people who need true clinicians to help them. It's very hard here to get people connected to systems, even people who have private health insurance, because we don't have appropriate access in the US to mental health services. With this, on top of these very life-threatening challenges, that we, I think, have to be creative and thinking about, well, how can we help to bridge some of these gaps and really close and narrow some of the, asking ourselves, who are the other stakeholders who need to be at the table here? And how can we kind of partner together and support each other in trying to really give the best? And Amy can, I'm sure, speak even much more eloquently about this than I can. But I know that people have concerns about, if they develop experiencing issues related to getting life insurance coverage or health insurance coverage, because living donation was considered a pre-existing condition. And so, I really don't know what's going to continue to happen as our policies keep changing. But I do know they won't themselves end up developing illnesses that then lead to end-stage organ failure, and then also just really protecting them and their abilities to be insured in the future.
Flying out to other countries for a kidney, because waiting time is that long here in Canada. And I think many people from the audience may have similar thoughts. Gorge also mentioned that this is happening in the UK as well. We know that it is happening to a small degree in Canada and Ontario, but there is research probably from multiple jurisdictions, but specifically Dr. Prasad at St. Michael's Hospital led a research project looking at patients who left and went overseas to get a kidney, and that study clearly showed that the health outcomes of those international transplants, where people go to different countries to get a kidney, the health outcomes are very poor. Frequently, there are major complications, including death and loss of graft when people are going outside. Nevertheless, if you end up getting a kidney and you come back to Canada, the system will provide you transplant care, but we very strongly discourage this practice because it is very risky. So by that, I don't know if there's any final comment in 1 or 2 sentences from everybody. I would go to Gertch first.
Probably the comment that I've labored the most. I think it's very difficult, but I think especially at this time over COVID, I think we can't overstate the importance of building trust with our diverse communities.
Yeah, thank you. Daniela?
I think that my one comment is that we all have a role to play. We all have important perspectives, and we all have an obligation to work together broadly with stakeholders to make a real difference.
Thank you. Amit?
Yeah, thank you, Esteban. I just wanted to thank everyone for an excellent session, and I have nothing further to add at this time.
Thank you. And Amy?
I have a visual. You put this on, right? Here's my mask, and look right here.
And hope.
We have to have hope. We cannot give up right now. It's, you know, we love our community. We love our kidney patients. We love our donors. We need to make sure everybody's safe. We need to make sure that they can ask the hard questions and we're accessible for them. We need to make sure the patient's voice is amplified so their needs are clear. And we need to work together right now and have hope.
Thank you very much. Yeah, thank you. And exactly, that's, I guess, the spirit that we will continue in 5-10 minutes. We will have patients contributing to the next session, and we will talk about our National Action Project. Thank you very much for all the speakers for your time and important, essential contribution. Thank you for your friendship and the partnership over the years for many of you, and we're looking forward to the next few years and hopefully better years and success in this field. Thank you very much.
Thank you, everybody.
Thank you for having us.